Thank you. Good afternoon. Thanks so much for the opportunity to present our work. This work was previously presented at the Association for VA Surgeons last month, and our other funding disclosures are listed here. Traditional surgical quality metrics focus on 30-day outcomes, including complications, readmissions, and mortality, while healthcare utilization includes all encounters in the healthcare system. In light of rising healthcare costs and a shift towards value-based care in the US, it is really imperative to understand the long-term needs of surgical patients beyond the 30-day period and across all healthcare settings. This is even more important for frail patients. Frailty is a clinical syndrome of decreased physiologic reserve and increased vulnerability in the face of a stressor such as surgery. And frailty has been associated with increased complications and readmissions, mortality, and costs after surgery. However, data are lacking on the rates of long-term healthcare utilization for frail surgical patients. Therefore, the aim of this study was to examine the independent association of preoperative frailty on long-term healthcare utilization through 2 years following surgery in a VA population. We utilized Vascular data from 2014 to 2018, which represents a 70% sample of VA patients, and this was linked to VA corporate data warehouse as well as Medicare data. We included all elective general and vascular surgery procedures, excluding emergent cases. This resulted in a final cohort of 172,429 procedures, 81% of which were general and 19% vascular surgery. Frailty was measured using the Retrospective Risk Analysis Index, or RAI-A, which has been previously validated for VasQuip. Patients were grouped into 4 categories: 0 to 20 robust, 20 to 29 pre-frail, 30 to 39 frail, and greater than or equal to 40 very frail. The primary outcome was healthcare utilization through 2 years, defined as inpatient admissions, outpatient visits, emergency department visits, and nursing home or rehab services. And we captured these across both VA and non-VA settings. Additional variables were collected as shown here. We performed unadjusted analysis followed by adjusted multivariate Cox proportional hazards modeling with competing risk to examine the independent association of frailty with healthcare utilization outcomes as well as mortality. Piecewise regression was then used to explore the variation in these effects over time. For the overall cohort, the mean RAI was 22.1. The distribution of RAI groups is shown here, with 12% of the cohort identified as frail or very frail. Focusing on population characteristics that are not included in the RAI score, overall 15% of veterans were Black and 59% were enrolled in Medicare. All baseline characteristics differed significantly by frailty status. ASA classification and comorbidities also significantly differed between groups. Regarding operative complexity, overall, most patients had procedures with an operative severity score or OSS of 2, but a higher proportion of frail and very frail patients had procedures with OSS 3. This slide demonstrates the cumulative healthcare utilization over the study period. 46% of patients had an inpatient admission with a median of 1 and a mean of 66 inpatient days, suggesting a subset of patients skewing towards longer inpatient use. While 83% of the cohort had outpatient visits with a median of 48 and a mean of 60. And 51% had an ED visit with a median of 1 and a mean of 2. Finally, 4% had nursing home or rehab encounters with median of 0 visits, but a mean of 275 nursing home or rehab days, again suggesting a small percentage of high utilizers. The rate of any subsequent healthcare utilization following surgery was 83% over 2 years. On unadjusted analysis, healthcare utilization varied significantly by frailty status, with frail in orange and very frail in red having higher utilization throughout the study period compared to robust in green and pre-frail in blue. Frail patients had higher baseline utilization in the 12 months prior to surgery, and while all groups had a peak in utilization right before surgery, post-operatively, a new higher baseline of utilization emerged for frail and very frail patients only. For our multivariate models, after adjusting for multiple covariates, including baseline utilization rates as shown here, frail patients in orange and very frail patients in red had an increased risk of inpatient admission after surgery beginning at 30 days, with an increase at 90 days, which sustained through 2 years. A similar trend of increased utilization for outpatient visits was observed starting at 90 days, though of lesser magnitude compared to inpatient admissions. The risk of ED visits also increased beginning at 30 days and remained significant through 2 years. Frail and very frail patients also had increased risk of nursing home and rehab encounters at 30 days, with increased risk at 90 days, sustained through 2 years. Given the overlapping confidence intervals for this outcome for some groups, within group significance was not observed here. However, frail patients still had significantly increased utilization over robust patients. Finally, as expected, mortality was significantly higher for frail and very frail patients throughout follow-up. Importantly, even pre-frail patients, depicted in blue, had almost 4-fold increased risk of mortality at 30 days and a 2-fold increased risk of mortality at 2 years as compared to robust patients. This study is not without its limitations. First, this was an observational study using administrative data, which can be prone to errors. Second, we included both VA-based and Medicare encounters, but we did not capture private insurance. Third, our outcome here was really all-cause healthcare utilization after surgery, and we did not distinguish between subsequent encounters related to either the index procedure versus those related to new surgical procedures or medical diagnoses. Finally, this study may have limited generalizability outside of the VA population. In summary, amongst over 170,000 veterans undergoing elective general and vascular surgery, nearly 12% of this population were frail or very frail. Over 80% of all patients had at least one type of healthcare utilization in the 2 years following surgery. And after adjustment and when modeled over time, frailty was independently associated with an increased risk of inpatient admissions, outpatient visits, ED visits, and nursing home or rehab encounters after surgery. In conclusion, frailty is a significant risk factor for increased long-term healthcare utilization and mortality after elective surgery, which remain high beyond the traditional 30-day surgical metrics. While we utilized a retrospective RAI frailty scoring system, the implementation of prospective, automated, and real-time frailty screening is ongoing in both VA and non-VA healthcare settings. Finally, healthcare utilization is important to patients, surgeons, and VA policymakers. Together, frailty and the risk of future healthcare utilization can help inform surgeon-patient discussions about risks, benefits, and appropriateness of surgery, as well as help policymakers more efficiently allocate resources. Thank you, and I'm happy to take any questions.